First of all, I would like to thank Mumbai Kidney Foundation and the organizing secretary and organizing chairman to give me this opportunity to speak on a very common topic which our general physicians face in their day-to-day practice. So topic today would be, how do we approach a patient with obstructive lower urinary tract symptoms? So if you can't explain it simply, you don't understand it well enough. So I'll try to make this talk as simple as possible so that it is very easy for the general physicians to understand. Here we have a 65-year-old gentleman who comes to the clinic and sits in front of you. He tells that, Dr. Saab, I'm not able to pass urine well. My flow is very poor. I have to strain to pass urine, and I don't feel that I am emptying my bladder well. So that is what is poor flow of urine, intermittency, straining, sense of incomplete evacuation. Sometimes when they don't take treatment on time for these symptoms, then they are unable to pass urine at all. So that would be inability to pass urine. So these are the symptoms what they will present to you. They also present to us with storage symptoms like frequency, urgency, nocturia, which I think Dr. Vikas Kumar is going to cover. So I will not speak much about it. So once you've taken the history, then the next part is the examination. On examination, you need to look out for a palpable bladder and the classical dull note on percussion. This is how you will come to know that bladder is palpable or no. External genitalia examination, rule out phimosis. If there is any meatal stenosis, itself gives us the diagnosis why the patient is suffering from these obstructive symptoms. Need to do a digital rectal examination to rule out if the prostate is enlarged or it is hard to feel, so that you can have a suspicion maybe we are dealing with a cancer of the prostate. After examination, we now need to keep few things in mind why the patient is getting this obstructive symptom. So it could be phimosis, meatal stenosis, urethral stricture, or an enlarged prostate. Primarily, these are the common symptoms which common diagnosis we will think of after taking an history examination. After the examination, next comes is the primary treatment. So you've seen the patient, you think that his bladder is palpable. So if possible, you can catheterize the patient in the clinic to relieve his discomfort. That is the primary treatment you can give to the patient in your clinic. Also, you can start the patient on alpha blockers like tamsulosin, alfuzosin, silodosin. So the patient gets relieved of his symptoms. After seeing the patient and giving the treatment, you need to advise some investigations to exactly know what is happening with the patient and what would be the diagnosis be. So investigations would be to do a PSA, free and total PSA. Free and total PSA is very important because sometimes when the PSA is in the gray zone, say between 4 and 10 nanograms per deciliter, then the free and total PSA ratio comes into play, which tells us whether any biopsy is required or no. Next would be to do a creatinine. Creatinine we do as a routine in all the patients presenting to us with lower urinary tract symptoms, because they are presented to us with a history of a low urine output. So whether it is acute kidney injury, CKD causing decrease in the output, or patient is in retention with back pressure changes, giving rise to raised creatinine, it gives us some significance about the creatinine at that time. Urine routine and microscopy is an extension of clinical examination. We do this to rule out if there is any urinary tract infection or we are seeing some blood in the urine. Sonography is again a extension of clinical examination. Sonography is done to rule out enlargement of the prostate, if the patient is retaining some urine inside with raised post-void residue. Are there any back pressure changes to see that kidney is dilated, there is hydronephrosis, hydroureter. Also, since we are dealing with an obstructive symptom patient, uroflowmetry is very important to let us know what is the obstruction we are dealing with, whether it is a urethral stricture, whether it is because of the enlarged prostate. Lot of information we get on uroflowmetry. And next is ascending urethrogram with micturating cystourethrogram. So on uroflowmetry, if you suspect that this could be a stricture, or on history, if you are suspecting that this could be a stricture where the patient gives that he has undergone few dilatations in the past, then the next investigation we do is an ascending urethrogram. This is a contrast which is injected in through the penis to rule out any stricture. You can see this. There is a stricture which the patient has formed and it's giving rise to obstructive symptoms. Next would be the investigations. Again, if once we have done all this investigation and if PSA is say more than 10 nanograms per deciliter, and on investigation you found out that there is no urinary tract symptom and there is no clinical suspicion of prostatitis, then you would be thinking in terms of probably cancer of the prostate. So the investigations which are required would be transrectal ultrasound guided prostate biopsy, maybe multiparametric MRI of the prostate, and a PET scan. So after we have made the diagnosis, what treatment would offer to the patient? So externally, there is phimosis. Phimosis, the treatment would be circumcision. If there is meatal stenosis, treatment would be meatotomy with a meatoplasty. Urethral stricture, either you can do an internal urethrotomy. This is an endoscopic treatment wherein we cut the stricture from inside, or a urethroplasty. Urethroplasty, you can see this. I have grafted a buccal mucosa on the dorsal part of the penis. Now, this is the same patient whose ascending urethrogram was put on the slide. He had a long stricture starting from the glans penis proximally to the mid-bulbar urethra. Now, if the patient has got an enlarged prostate, the treatment would be initially a medical management, wherein you can start with alpha blockers like tamsulosin, alfuzosin, or silodosin, along with 5-alpha reductase inhibitors if the prostate size is more than 40 grams. In case the patient is not responding to medical management, or in case of severe bladder outlet obstruction, then obviously surgery is indicated. In today's world, majority of the time we are doing holmium laser enucleation of the prostate. TURP is again a gold standard for enlarged prostate. Millin's prostatectomy would be for prostates which are more than 100 grams, or in cases where the facility of HOLEP is not available. You can see this. I have removed this enlarged prostate of 340 grams. This was a huge prostate where the facility for laser was not available, and we have used this modality to relieve the obstruction of the patient. In case of enlarged prostate with diagnosis of cancer of the prostate, treatment would depend on what stage the patient has presented to you with. It could be either radical prostatectomy or radiation therapy. In metastatic or locally advanced case, it would be hormonal treatment with radiation therapy. So to end with, I hope I have kept up to the expectations of my family physician. So presentations aren't about the presenter, they are about the audience and what the audience needs. If the presenter is talking too much, it's usually a sign that he or she has forgotten who is important. I hope I have not talked too much and my slide would have been as simple as to understand, and this would be their take-home message. Thank you so much. And